you all sitting in the back, I've got malaria and flu, and I really don't. You want to scoot up? Anybody? Good. First time victims. Great. So I hope you enjoy it. It's got some depth and some heaviness to it, but I think it's an important issue, and if there's anything of interest to you, I'm going to move through it pretty quickly. By all means, you can email me, Morrow, J3 at UTHSCSA.edu. That's Morrow, J3. So just holler if you have any questions, and any feedback can be sent to him. That's negative. Tangled up in blue. Sorry, no disclosures, no financial relationships, sadly. The objectives for today are to identify the risks, benefits, and harms to attempted resuscitations in patients with advanced cancer, evaluate ethical criteria for overriding patient or surrogate requests for everything in a code blue, and to compare key strategies for managing conflict over code status in the setting of anticipatory futility or harm. Now, I know this sort of stands out as a little different than some of the other talks you've been giving, you've been participating in here. I do think it's relevant to not only folks with advanced cancer, but people with any chronic comorbidities, emphysema, dementia, and the many conditions that affect our elders. What I'm going to do is walk through a little background on myself and historically, as well as a clinical case. And I will walk through then the history of resuscitation as I've researched it. And I'll identify the outcomes of resuscitation that us in the field should be aware of and we should be educating our families and seniors about. I'll talk about how we predict outcomes, both from the clinical and patient or family perspective. I will then identify the harms of resuscitation, which I think is really the moral center of my argument. And then we'll talk a little bit about how to determine code status in terms of our legacies historically of the rights movement and the language of medical futility. I will outline some strategies for managing conflict, including how to say no when you need to. So this is the frontispiece to Andreas Vesalius's Fabric of the Human Body. This is, as you can tell, an anatomy lab, human vivisection. And I bring this to you because I think it's an amazing graphic from over 500 years ago. But also because it represents, for many physicians, the first patient encounter. For many physicians, your first patient is dead. And the first relationship you have with that patient is one of violence. It's extremely physical. And I can take you back, I can take myself back to the scene of the anatomy lab with saws and tearing the human body to pieces for the greater purpose of learning so that we could go on to help others. But in some ways, this is my first patient. Now, the anatomy lab is not the only vision of being a physician that I carry with me. I also carry with me several images, for better or worse, of what a physician can be and what a physician can do. For example, here's Sir William Osler, the consummate clinical physician who was reputed to have been able to diagnose heart failure from across the room, heralded an era of scientific acumen brought to bear for the patient of benefits, and was also extremely compassionate and able to relate, as you can see here, to ailing children. This image represents an experience I had as an intern. So I'm walking the floors at night, doing my duty, cross-covering for probably 100 patients, when I hear the nurse call out from the corner room, "Doctor, help." I turn into the room, and there's a 55-year-old woman who has end-stage tuberculosis. I found this image online. This is not her. That looks exactly as I remember this woman. And she was not breathing. She was unresponsive. I asked the nurse asked me to help, so I initiated compressions, and she went and got other help. Other physicians came into the room. Soon it was the big scene, the code scene. I broke every rib in her body during compressions. My senior resident came in with her paper chart, flipping through it, saying that she is full code, but D and I do not intubate. Which meant that there was nowhere to go with this. I was her heart. I was beating her heart by pushing it from the outside. But whether or not her heart could have continued with the breathing machine, I can't say. But it was obviously a case where there was no hope of recovery, and when somebody senior to me said stop, I stopped, and she expired. And that experience was very difficult, because I realized at that moment, not only do I have the opportunity to help people, but I also have the opportunity to harm people. And I didn't like the feeling in any way. It was very emotionally difficult. Again, not the only image I carry with me. I've gone on from residency to practice as a hospitalist and a specialist in palliative care. And I don't rescue everybody. I'm human, but I do feel very good about my ability to help people cope with illness and to be present at the time of suffering, to be a witness to suffering. And I find joy in what I do, even though there's a lot of sickness and there's a lot of dying out there. But I'll tell you, there's an image that I carry with me that comes when I moved here to San Antonio, driving along I-10, listening to NPR. I hear about this study being conducted at Texas State University, in which this researcher conducted a study seeking volunteers for people to donate their bodies after they died. And the study was intended to look at the nature and rate of human decomposition when left to the elements. And this could be helpful for medical examiner, science, coroners. So the description of what they discovered was quite graphic. I actually had to pull over. So I apologize in advance for it. But I'll share with you that what they learned was that the rate of human body decomposition is accelerated by the presence, as you might expect, of vultures. And the way in which vultures contribute to the decomposition is very physical. They approach the thorax, and they take their mighty talons, and they latch onto the ribs, and they beat their mighty wings, and they crush their way through the thorax to get at the internal viscera. And what I did not like about hearing that graphic description was that I identified with it very much. It took me right back to that scene. And I just felt this visceral feeling of doing more than healing. So this mixing of images that I carry with myself of aspiring to be a healer, to live up to the noble ideals of the profession, is in some ways distracted or contaminated by this vision that I'm also somebody who's capable of wielding technology and my skill as a physician in a way that causes harm. And I have to ask the question, and this is something I realized on the side of the road, is the harm just to the bodies, or is it also to me? Is it to my other providers? So not to get too heavy on you, but it does make me think about the rise of technology in the 20th century and the collateral damage that comes from our scientific endeavors. You may recall the understatement of the 20th century when Robert J. Oppenheimer witnessed the explosion of the atomic bomb in New Mexico and uttered the words, "It worked." He later described his thoughts in that moment after uttering that understatement. He said, "I am become death, destroyer of worlds, a line from the Bhagavad Gita. So, in light of the collateral damage that comes from the rise of technology and thinking about where the injury occurs and the more motivation, the strength of your motivation to try to avoid harming people, let's go through a case that happened here in San Antonio. I fictionalize it to protect the innocent, more importantly, the guilty. That was a joke. Mr. Gary, he's a 52-year-old gentleman, Mexican-American. He's a sculptor, he's a bachelor, he has strong faith, and he has a sister who is present in the hospital. He comes in with stage 3 signet cell carcinoma of the appendix a year previously and now presents with pain. He has a small bowel obstruction that is emergently resected, and this is the beginning of a 5-month hospitalization. If you've worked in the hospital, then you're familiar with the way in which a simple admission becomes a very long, complex admission. His sister was present every day as his advocate, absolutely by his side through this journey. During the course of the admission, there arose serious conflict over requests for treatment and code status. The surgeon said, "I'm sorry, there's nothing else we can do," at the point that he developed further recurrent obstructions and enterocutaneous fistula, abscesses, or little tunnels that are formed by infection from the intestines to the outside. Nothing could be done. The surgeon said, "We'll kill him if we take him to surgery. I'm sorry, there's nothing else we can do." Cancer doctors also said, "I'm sorry, there's nothing else we can do." They actually came to loggerheads, and she advocated for getting another round of chemo, which he got, and it nearly killed him. He went to the ICU, was on the ventilator, but somehow came off. And at that point, the cancer doctor said, "I'm sorry, there's nothing else we can do." So let me just pose the question for you. At that moment where the surgeons and the cancer doctors have said there's nothing else we can do, what should his code status be? How would you go about determining it? What are the benefits and harms of attempting resuscitation for Mr. Gary, for his sister, for the other healthcare providers who were witnesses to the possible scene? How would you manage conflict in this setting? What could you do to support his sister, his family? Do the providers who are involved in the daily care need support? And how would you respond if you were walking by his room and the nurse called out, "Doctor, please help," or "Anyone, please help"? Would you do everything if that's what the record suggested his code status was, full code? What other options would you have, and how might you justify overriding he and his sister's stated preferences? Not just theoretical. Let's go through a little background on the history of resuscitation to add some context. So, the Bible describes Elisha, disciple of Elijah, who leaned over a dying child and breathed into him and placed his body upon him to warm him and resuscitated him. This is the first documentation of resuscitation. Here we have a picture of Alexander the Great, whose soldier who had fallen, had been wounded in the neck and was suffocating. It is reported that Sir Alexander the Great pierced the neck of this soldier with his spear and saved his life. You'll see his method of informed consent slightly differs from ours. Here we have Galen, considered by some the father or grandfather of medicine, who discovered the connection between the heart and the lungs as physiologically connected entities. So the Babylonian Talmud describes a story of a lamb that fell into the water and nearly drowned, and who was rescued by the placement of a hollow reed into its neck. So I looked at this in the internet and found here's a picture of a drowning lamb. Here's an album by Corey Lamb called Drowning. And here's Lou Reed, who sadly passed. So this is another picture from Vesalius, who was the great anatomist and documenter of human anatomy, who actually showed through the movement of the heart resulted in the movement of the lungs. So it took a step further, the studies of Galen, by studying the human body. Now Paracelsus is the botanist and physiologist who is quoted as having said, the dose makes the poison. He was the first to attempt bellows to nose resuscitation. which I think is pretty clever. In the 1700s, William Tosack, a surgeon, rescued a collapsing coal miner who compressed the lungs from the outside and was able to stir this fallen miner. Now, the Dutch have a lot of experience with drowning because they're below sea level, it's a naval port, they drink like crazy, and those little canals are windy. So everybody's drowning and falling, so they had a leg up on the rest of us. And their people developed the chest compression method, eerily described here in this plate that I found online. I'm going to tell you about the Society for the Recovery of Drowned Persons in Holland and the Dutch Humane Society, who offered guidance for victims of drowning. You're going to like this. So this is their strategy for attempted resuscitation. First, warm the victim by lighting a fire, burying him in warm sand, placing the body in a warm bath, or in a bed with 1 or 2 volunteers. Remove swallowed or aspirated water by positioning the victim head lower than feet. Vomiting was induced by tickling the back of the throat with a feather, which is why I carry a feather in my wallet. Stimulate the victim, especially the lungs, stomach, and intestines, by such means as rectal fumigation with tobacco smoke or the use of strong odors. Restore breathing with a bellows, and of course, no resuscitation should attempt without a good old-fashioned bloodletting. And in case you doubt it, this is a plate that describes rectal fumigation. What I like about this particular slide, and I see your expressions, they're priceless. I want to take a picture. It says, a brave German doctor administers the enema of tobacco smoke. I don't know, I think the patient might get credit for being brave as well. This is a rectal fumigator that a physician could carry around with them. So this is the real deal. Go to eBay, they're actually for sale. Not that I've looked. So coming to the 20th century, cardiac massage was taken to the next level by Friedrich Maas, who died in 1909. His technique for rapidly compressing the thorax was obscured for decades. I did find a picture of cardiac massage online. So interestingly, here we have the pulmotor, which was used in the 19-teens. So it's described that during surgery, the surgeon, whose name eludes me, I'm going to get to in a moment because he developed a defibrillator as well. Actually, during surgery, a patient started to die, the heart stopped while doing a sternotomy. So he called the fire department to bring the pulmotor, please. And so the fire department comes rushing to the operating room, bringing the pulmotor to be attempted on this patient. There we go. Claude Beck developed, that's him, developed he's at Western Reserve University. He developed his own cardiac defibrillator, which applied a current to the chest in an attempt to restart the heart. In the 1950s, the drinker respirators, or the iron lung, applied negative pressure to assist in breathing, widely disseminated in the 1950s. And William Couvenhoven, who I would consider sort of putting us on the current road towards what we now recognize as CPR, famously published an essay in which he described a study that was performed on animals. So I left out the article, but what's really fine about this article is that he describes the success rate of resuscitating animals through external cardiac massage and the use of defibrillators. And in the 20 animals, about 70% were permanently resuscitated, which I think is fabulous, because not only did he resuscitate the animals in the moment, but they had managed to live forever. And he also recommended that that external cardiac massage could be used by anyone, anywhere, at any time. Right? So putting us in a mindset that we are able to be rescued from almost all death, at least all cardiac death. The American Heart Association published its first standards in 1906, drawing directly on Covenhoven's article. What they argued was that CPR should be widely available. However, it is not indicated in a patient who is known to be in the terminal stage of an incurable condition. Right? So right from the outset, while it was recommended almost universally, they did identify a subset of the population that would not benefit. The recommendations from the American Heart Association were reiterated and elaborated upon in every issue of their publication. So here in 1974, they state that CPR is not indicated in certain situations, such as the case of a terminal irreversible illness where death is not unexpected. Right? It makes sense. I like that they applied this type of prudence to the early recommendations. In 1980, a patient's family should understand and agree with the decision, but the family's opinion need not be controlling. So already they're recognizing that conflict occurs over whether a person should have resuscitation attempted or not. And their first foray into this type of conflict is to say that the physician should have control over the decision. If it's not indicated, then it's not indicated. So I want to fast forward to 2010. There are a couple of other iterations of these recommendations, but really the rub is here, and these are your current standards recommended by the American Heart Association. An objective criterion for medical futility was defined in 1990 for interventions in the drug therapy as imparting a less than 1% chance of survival. So medical futility, according to their research, means that something has a less than 1% chance of survival. Although this may be controversial, it is a basis for current futility research. Let me add parenthetically what current futility research. The article that they said less than 1% on came out of a journal of bioethics. There was no research done. The authors just said, well, we think that something would be futile if it had a less than 1% chance of working. So it was sort of pulled from thin air. Nevertheless, an obvious example of an inappropriate or futile intervention is providing CPR for a patient who has suffered irreversible death. While that's not a controversial statement, we have to ask, what is irreversible death? Is there any other kind of death? And here we go. Without objective signs of irreversible death, for example, decapitation, rigor mortis, or decomposition, and in the absence of known advanced directives declining resuscitative attempts, full resuscitation should be offered. So this is your physician's current standard for whether or not to do CPR. If the patient is decapitated, no. If rigor mortis is set in, no. If they're decomposing, then no. Advanced directives saying they refuse it, no. But otherwise, CPR should be done. And this is the connection with Covenhoven and Oppenheimer. We have the rise of technology, and we quickly lose the ability to discern when it's appropriate to use it. So let's look at how effective it is. So, out of hospital survival is about 5%. Your average person walking in the mall collapses, 5% chance of surviving from that scene through the subsequent hospitalization. In the hospital, survival is about 15%, probably because you have all the technology surrounding you. But still, that's lower than many people would otherwise believe. 30% of the time, a heart rhythm will be restored during the attempted resuscitation. 20% of patients will survive 24 hours, but to leave the hospital, about 15%. If you have cancer at the time that your resuscitation is attempted, survival is 6%. That's at best. That's based on a study of a couple of thousand patients. I'm going to show you some evidence of a finer lens, and you'll see the numbers are not as encouraging as that. For example, here's one study looking at CPR for patients who were in an ICU over a period of 7 years. 8% of the patients underwent CPR. Of those patients, 1.6% survived to discharge. And their study pointed out that the cost of care in the subsequent days for those patients was more than double the usual cost. Here's a study that I'd like you to remember. This is out of MD Anderson. So if you take 243 patients in a comprehensive cancer center, and you take all of those who have arrested in the hospital, and you ask physicians to evaluate the chart at the time of admission, and you ask the physicians to look at all the clinical data and documentation of those patients, and you ask the physicians, okay, of these patients, and they're blinded to the outcome, of these patients, which ones do you think would have an anticipated arrest? That if they coded, you'd be like, oh my gosh, totally, they were going to code. And which ones would you be totally surprised that they were going to code while in the hospital? For a sudden arrest, that's usually a rhythm disturbance, an acute airway obstruction, or a pulmonary embolism. An anticipated arrest, you might figure, the physicians are looking for things like the patient's already deteriorating despite aggressive interventions like sepsis, shock, acidosis, multi-organ dysfunction. So here's your 244 patients at the top, and of those on the right who had a sudden arrest, which was 30% of the patients, 57 died during the code, 16 got return of circulation, 3 of those had a subsequent arrest, but total, 16 survived and left the hospital. So 16 out of 73 is a little better than the national average in terms of surviving CPR, just on its own. That's better than the national average. But of course, you got to put that into context, because there were 171 who also arrested, and in these were expected. They were sick enough that the docs who evaluated their initial presentation said this patient had those criteria that puts them at high risk for coding. Of those 171, 149 died during the code, 22 had a return of heart rhythm, all 22 of those subsequently arrested again and died. 0 left the hospital. So what does that tell you? It tells you we have a sense who is not going to survive CPR. What do patients see? On television, primetime television in the United States, survival rate from CPR is 67%. I wish I had thought of that study before they did. 46% survival among people with CPR on British television. You can expect the numbers are a little more realistic. They got the stiffer upper lip. I don't know if that affects their mouth-to-mouth resuscitation. In Holland, you know, they've been dealing with the drunk sailors for years, so their survival rate on television is a little more realistic at 19%. But patients aren't the only ones with the rescue fantasy. We love this stuff. We come to the hospital every day because we like to help people get better. And this sort of rescue mentality or rescue fantasy is something that we are all guilty of. It's actually a very good thing. It's what motivates us to do the hard work that we do. So let's break it down a little bit in terms of what doctors and patients are thinking. So here's a study looking at patients, pardon me, who had a semi-structured interview after a code status conversation, and asked them, okay, well, why did you choose to be a DNR, and why did you choose to have the full code? I like this study because it provides a little texture to the types of reasons that people have when making decisions. Some of it's intuitive, some of it's not. So one reason why a person would choose to be full code, I like life. Life has been very good to me. The first thing I thought of was my daughter. Then I said, yes, yes, resuscitate me. I said, just do what you have to do to keep me alive because there is a lot that I want to do. I would want to be resuscitated. If I didn't, then why would I come to the hospital? How about physicians? So how do physicians do in estimating the survival of patients who are undergoing arrest? So here's a cool study. They took faculty and residents at 3 hospitals, and they did a chart review of 478 cases in which people had CPR, and then they developed 713 case scenarios based on these, and they knew the outcomes of the actual cases that they could attach to these synthesized cases. And they had 51 physicians evaluate them. And what they did is, this is too small, I can appreciate from here. But what this is a sheet. That is what they reviewed. At the top it says, 80 years old, urosepsis, no cancer, no dialysis, sepsis, yes, here's the vital signs, blood pressure 146 over 84, white count is 9, creatinine is 0.6, etc., adding some context so they can make a guess to these questions. If this patient codes, I think the probability that he or she will survive the code itself is 0 to 100%. And then the next question is survival to discharging from the hospital, 0 to 100%. How did we do? How did the physicians do? Because we knew their outcomes from the real cases. Physicians were inaccurate, unreliable, and non-discriminating. No better than chance. The predicted mean probability of short-term survival, we did okay at 39% compared to an actual survival short-term of 36.6%. But long-term survival, leaving the hospital, they predicted 26.5%, and the actual discharge survival rate was 3.8%. Now, those of you involved in the world of palliative care may recognize this slide. I put it here because what this represents are the trajectories of illness. At the top, it's described as chronic, progressive, eventually fatal illness, and the elderly typically follow these trajectories. At the top, you see mostly cancer, where people hang on, they do pretty well until they don't, until the cancer spreads, injures other organs, and the decline towards death. In the middle, you see long-term limitations with intermittent serious episodes related to heart failure, lung failure, progressive illness. And I think it's empowering to let families know of this type of trajectory. They often don't understand that after grandma's heart failure exacerbation, she's not supposed to get back to 100%. You just do the best you can to get her as strong as possible. We don't know when that next episode will be, and we don't know when the final episode will be. But it gives some context for families to understand what illness typically looks like. In the bottom, you have mostly frailty and dementia. And I put this here, I know it's kind of heavy and dark, especially, here I am on this chart. But it's the knowledge that we have from centuries of experience in medicine and nursing and chaplaincy. We don't live forever. And there are certain trajectories of illness. And if doctors know this, doesn't that guide how we use our interventions wisely, safely, effectively, and compassionately? I tell my residents, dying is a predictor of death. If you see that somebody is dying, it's a good time to talk about what's coming. And just because you don't say the D word doesn't mean it's going to happen. So, what are the odds that Mr. Guerra would survive a code blue? Is resuscitation attempt futile? And how would we manage conflict in his case, now that I've described some of that context? Well, let me tell you that I gave you a situation where he has signet ring cell carcinoma, 5-year survival rate, all things considered, is 20%. That's a bad actor. That's not a cancer that you want. The reason why that is, some of these abdominal cancers are spread by the time you diagnose them. That lowers their survival rate. And so he comes in with an already bad cancer. He also is having an impending abdominal crisis. And a week before he died, he was on 125 micrograms an hour fentanyl for his abdominal pain. Over that week, he developed even more enterocutaneous fistula. His belly got rigid. His white count went from 8 to 30. And his fentanyl requirement went from 125 to 1,400 micrograms an hour to control his pain. So we all recognize that he had an impending abdominal crisis. When his intestines finally ruptured, what were we going to be able to do to save him? The surgeons had already said no surgery. There was no putting the cancer back in the bottle. And in this week, the sister insisted on him being full code. When you turn to him, he looks out the window. He's taken on the role of the passive patient, and his sister has compassionately adopted the role of representing her brother. So we had a meeting, and I was there with the hospitalist, and we sat down with her and him, and we said, I'm sorry, but when his gut finally ruptures, no CPR or breathing machine can fix that. He will simply die, and there won't be anything we can do about it. What we'll promise you is we'll rush to the scene and make sure he's not suffering. But we're not going to attempt resuscitation or put him on a breathing machine. And a DNR order was implemented, and we went to everybody from the on-call administrator to the ICU teams and said, here's the case, we've entered a DNR order. You have the right, when he codes and you're called to it, to withhold CPR because we're putting that order in. We also said, if you arrive on that scene and your conscience says, I can't listen to that order because it wasn't agreed upon by this sister, or if the sister is there telling you, do everything, I don't care what those other doctors said, it is your right to go ahead and do that. But we're trying to empower you to forego DNR, forego CPR if you desire. We handed the patient off to the next team. They did not feel comfortable with overriding the sister's request. So instead, invoked the Texas futility law, which I'm going to describe for you. What it says is you'll honor patient or family's wishes, but then you issue them 10 days to find another place to take their loved one. And at that time, then you'll override their wishes. I call it, you don't have to go home, but you can't stay here long. And it was invoked and implemented, and literally that night, he coded. Became hypotensive, unresponsive, his heart stopped, he stopped breathing. And for an hour, he was given chest compressions, epinephrine, intubated. They got the heart rate back, it was touch and go for an hour. He was taken to the ICU and died there. So another aspect of the context, which I'm going to breeze through and I'm happy to talk about after the fact, but it does give some context to how we got here. In 1914, the case of Schloendorf, in which Chief Justice Benjamin Cardozo famously described the right that individuals have to control over their own body, was articulated. In this case, Ms. Schloendorf had a uterine mass that the surgeon felt was at risk for being cancerous. She agreed to a biopsy. She said, but don't take out my uterus. Do the biopsy, and then we'll talk afterwards. And if you recommend taking out my uterus at that time, we'll talk. Well, he did the biopsy. It looked bad to him, and he took out the uterus. She sued him. And it went to the United States Supreme Court, and she won. And this indoctrinated the notion of autonomy as the preeminent value involved in doctor-patient relationships. Fast forward to the National Research Act, which embedded the language of informed consent into law. That was related to human subjects research, but it also applied and was analogous to what was going on the clinical side. You may be familiar with the court cases of Karen Ann Quinlan and Nancy Cruzan, both cases in different states in which parents sought removal of life-supportive measures on their young daughters. In the case of Cruzan in Missouri, the United States Supreme Court ruled that the Missouri Supreme Court, the state of Missouri, could hold a standard called clear and convincing evidence. That is to say, you can withdraw life support on your loved one, but as long as there's clear and convincing evidence that that's what they wanted to do. And ultimately, the parents found that evidence through testimony of a college mate of Nancy Cruzan, and they removed life support. Karen Ann Quinlan was in New Jersey, and that only went to the State Supreme Court of New Jersey, but it created a language for which people can put in writing their preferences. And that actually led to the state of California implementing the first ever advance directive type policy. In the 1990s, the Patient Self-Determination Act was passed, and this states three things: that patients have the right to facilitate their own healthcare decisions, to accept or refuse medical treatment, and to make an advance healthcare directive. This is why every hospital in the United States has to ask about whether you have an advance directive. They don't do much when they ask that question, right? Do you have an advance directive? Yes, no, great, next. But this at least got it as part of the process. Throughout the 20th century, we have an emphasis on informed consent, pardon me, freedom from bodily coercion, and a right to withhold and withdraw treatment. Simultaneously, we have the rise and the end of the 20th century of what's called medical futility. Futility itself means having the quality of no useful result, uselessness. A futile act. It comes from the Latin, futilis, leaky, like a leaky boat. I discourage the use of the language of futility, especially with patients and families, because it comes across as saying, what? My mom's not worth it? So to avoid that ambiguity, I recommend we simply don't use this type of language. In the literature, though, there are different kinds of medical futility: physiologic, imminent demise, lethal condition, or qualitative. If somebody's decapitated, then any further treatment would be futile. I totally get that. Qualitative, we tend to shy from. Oh, that type of, well, I wouldn't want to live that way, therefore treatment is futile. We try to avoid that because we feel uncomfortable about it. And you'll see that my argument for withholding attempted resuscitation does not require making a judgment about quality of life. So futility got its legs in the early 80s when a New York grand jury investigation found that LaGuardia Hospital had been basically committing a crime. Physicians were putting purple dots on patients' charts to signify to nurses that the patient would not survive CPR, therefore walk slowly. So you've heard of a slow code. and that's where it came from, the purple dot system of LaGuardia Hospital. Physicians lost their licenses, and the hospital temporarily was not able to see patients. And in the 1980s, the Wengele case up in the Midwest, and baby K near Washington, D.C., an anencephalic baby born without a brain, who kept presenting to the emergency room. In 1995, the Gilgan case. I guess most importantly, for time's sake, we'll talk about the Houston Hospital Consortium in 1996. Very interesting. So these are your major hospitals in Houston, who, and the executive leaders of these hospitals come together and say, we've got a problem. We have patients in the hospital who are receiving life support but not benefiting from it, and our staff feel stuck. They're in distress. What can we do? What options do we have other than just indefinite life support until the patient dies despite the life support? And they came up with a protocol for limiting medically inappropriate treatment based on an open and fair process. This led to the Texas Advanced Directive Act in 1999, and within that, the Texas Health and Safety Code, Section 166. Some of us call it just Section 166. And this includes specific mechanisms for advanced directives in the state of Texas, durable power of attorney, out-of-hospital DNR, and, as I stated, a procedure if not effectuating a directive or treatment decision. This procedure involves the faculty, the staff saying, we're continuing life support in a patient who's not benefiting from it. They solicit ethics committee review, who then reviews the case. If they concur with the clinicians, then the family is notified that they have 10 days before the patient will be transferred to another facility. And if the family can't find another facility, then the treatment will be discontinued. And it creates this process whereby the families can still seek appeal from a court, but it tries to keep it local within the hospital. Because prior to this, it's all, prosecution or not. This is the advanced directive created by the state of Texas. And both for terminal conditions on top and irreversible conditions on bottom, patients have two choices outlined for them. I don't know if you can read it from there, but I'll read them to you. The first box is, I request that all treatments other than those needed to keep me comfortable be discontinued or withheld, and my physician allow me to die as gently as possible. Doesn't that sound like an extension of the patient's rights movement, the autonomy, the ability, and the authority to withhold treatment that you do not want? Maybe treatment that you don't want would be battery, or assault, or negligence. Therefore, that first box makes sense to me. The second box says, I request that I be kept alive in this terminal condition using available life-sustaining treatment. So I have to ask, why is that box there? I don't want to be glib, but I request that I have a pony. Why is it that we create a statement that says, I want everything always, no matter what, against any other medical recommendations? How is that an extension of the patient's rights movement? It's not. It's the extension of something else. But what it does, it creates a situation where, yeah, we respect patients' wishes through this whole documentation of informed consent process, through like advanced directives, but we've made it so that we actually have an option, that there's no evidence here that this was done with the counsel of a physician. Right? This is just, as far as we know, somebody checks a box, and now we're locked in to respect their rights at all costs without using any medical judgment. My concern is that Section 166, which creates that process, you don't have to go home but you can't stay here, makes it easy to request unrestrained life-sustaining treatment in all clinical circumstances. It's an uninformed consent process for patients. It describes medically unnecessary treatment in the most neutral of ways. I'm going to argue that it's not that it's medically non-beneficial. It's that it's harmful. And I think that gets us more mileage and is closer to the point. It also creates a standardized, lengthy, and polarizing process for overriding such requests. And maybe it's better suited to cases of ongoing life-sustaining treatment rather than cases of future life-sustaining treatment. So, let's ask, was Section 166 appropriately invoked in the case of Mr. Guerra and his sister? Is there a difference between life-sustaining treatment and anticipatory life-sustaining treatment? might we consider some cases of imminent resuscitation, like Mr. Guerra's, to be actually an instance of anticipatory futility? It's not that what he was getting at the moment, the antibiotics, the wound treatment, and the pain medicine, not that was futile, but that anything that further escalated technological intervention was at high risk for not only not helping, but causing new harm. And what other ethical criteria can we use to override such treatment, requests for such treatment? And I think the answer we've had with us for a while, and that is primum non nocere, or first do no harm. It's attributed to the oath of Hippocrates, which actually states to abstain from doing harm. The phrase first do no harm is attributed to Thomas Sydenham in a book by Thomas Inman in the 1860s. So maybe medical futility is a round peg for a square hole. Maybe harm would be a better fit to describe why we should avoid attempting resuscitation for Mr. Guerra. I'm going to outline 3 ways in which it's possible we're harming patients who are unlikely to survive CPR. The first is to the body itself. In a prospective study looking at 700 cases of autopsy, CPR itself caused thoracic complications in 43% of them. The severity of thoracic complications increased the older the patient was and the longer the CPR was performed. Makes sense. Abdominal viscera were ruptured in 30% of the cases. And life-threatening heart and great vessel aorta damage was actually caused by CPR in 0.5%. Now, that's to the body itself. What about to the providers who are present? I'm going to argue that performing such a physical act on somebody who is dying and has no chance to benefit from it introduces a new harm that in the nursing literature is described as moral distress. This is where you know the right action, but you feel powerless to perform it. For nurses, the major sources of moral distress in the literature are primarily continued life support, even though it is not in the best interest of the patient, inappropriate use of healthcare resources, and false hope given by teams or doctors to patients and families. One study looking at moral distress among physicians similarly found that pressure to follow families' wishes despite not being in the patient's interest is a chief source of moral distress. What are the signs of moral distress? Frustration, anger, or a sense of threatened professional or personal integrity. What are the consequences? Well, anybody who's subjected to practices in which they feel powerless to do what they feel is right is going to lose the ability to recognize ethical situations. They might also engage in conscientious objection, which can be both productive, and then they speak up for something that they believe is right. It can also be destructive in terms of collateral or horizontal violence to peers or negative team behavior. And importantly, it can lead to burnout and leaving the field. So I ask, not just doctors and nurses, but what about other students, residents, and other staff who are present on the scene for attempted resuscitation in patients who are otherwise dying? And of course, I'm reminded of the physical nature and what's at stake. So we have the bodies, we have the providers, but there's something else that is lost or injured in the moment of attempted resuscitation. Here we have an image of the death of Socrates and his disciples who are lamenting his death. Now, Socrates died because he was poisoned as a criminal punishment for having corrupted the youth based on expressing his views through education. He chose to die rather than change his practices. So I'm just going to call this a noble death, or virtuous death. Here we have an image of the Totentanz, a medieval notion of what happens to the remains of the body after death, rising up through the ground, dancing on the grave and going towards heaven, because released from its mortal coil, the soul can now rise to heaven and live eternally there. That's the happy death. And I apologize for the intensity of this picture, but I do recommend going to this Pulitzer Prize-winning piece of photojournalism by Renee Beyer in the Sacramento Bee, which you can find online. There are 4 sections to it. This image represents Cindy French, Derek Madsen's mother. Derek is there laying down. He was at age 10 diagnosed with neuroblastoma, and and died a year after diagnosis, and this photojournalism piece represents his journey and his mother's journey. Here you have a nurse assisting the mother with providing comfort to Derek in his final moments. And I'd ask you, if in this scene, when Derek's heart stopped, what would the role be for attempting CPR? What sort of harm would be done? The answer I would give is to his story, to her story. She needs peacefulness. He needs a peaceful passing. So the harm that comes from ACLS protocol, from CPR, and somebody who cannot survive, is literally done to the body. Importantly, it's done to the staff and the other providers who are present and involved in the scene. And it's also done to the story that is told in the wake of death. I'd also point out this nurse, because she's on this scene, and she's doing the best job she can, but she's all business, right? She's probably got 4 other patients she's going to go see that day. So to me, it highlights also the role of moral distress. Even though it's terribly sad and can cause compassion fatigue when you're present for death, if you feel that you've done the best you can and no new harm was introduced, it may empower you to continue your job. The context of terminal illness is one of desperation and advocacy. It's a time of emotional, financially, and family distress. I think of Mr. Guerra's sister, right? She's just advocating desperately for her brother. It's a time of anticipatory grief, where feelings of anger and denial and guilt are already present even before having lost someone. And it's a time of life and death decisions that are extremely high stake. This is a perfect setup for irrational risk-taking, for harm, and for unhealthy conflict. So I'll ask, if surgeons and oncologists can refuse to offer therapy based on the risk of harm or the absolute risk of harm relative to benefit, can other clinicians similarly refuse resuscitation? It's the analogy, I think, of pre-chemotherapy or pre-surgery risk assessment. Right? I also practice internal medicine, hospital medicine, and I'm asked to evaluate a patient. Are they safe for surgery? Are they cleared for surgery? What I'm doing is I'm assessing the risk of harm from that intervention prior to it being done. Can we do that same type of assessment for imminent CPR? Can we risk stratify for code status? And I think we can based on the study I showed you from MD Anderson. If clinicians can assess that a patient is at high risk for resuscitation and they already have high risk for cardiac arrest and they already have metastatic cancer, and of those patients 0% survive, then maybe we have a tool for risk stratifying whether patients will survive. So, if we're going to work towards foregoing CPR, despite a sister or other family member requesting it, we'd have to ask, how are you going to say no? How are we going to do it? So one piece of the literature argues for carefully omitting full code or DNR from their options, just like we don't say, and when they come in the hospital to patients, and would you like an LVAD, a left ventricular assist device, or an extracorporeal machine to circulate your blood? No, we don't even ask. Those types of technology are only used in very specific situations. So our authors argue, well, we should do the same with CPR, don't even mention it. And then go back to the slow code. If the family says they want everything and we don't agree with it, well, fine, don't argue with it, just go slowly. But I would argue that there's a role of deception there we might not be comfortable with. Another is to not offer it. And these authors argue for an explicit hospital policy and consider changing DNR to the default option, which in Wisconsin nursing homes, that is the default option. But I wonder if Texas law would permit a default DNR, and I wonder if our population is a little more heterogeneous than Wisconsin nursing homes. So for managing conflict, the best tool you can have is Chuck Norris. Short of that, while he's driving to the hospital, the next thing we can do is anticipate and prevent it. This is sort of a big picture approach. We need accessible and longitudinal provider-patient relationships. We need research that illuminates and enhances medical decision-making. Why do people choose things? is very interesting research in the cancer treatment, where if you tell a patient there's a 15% chance of response, and you just say the number, versus showing them a graphic or a different kind of graphic, they'll actually make different decisions. We need to understand better how people make decisions based on the information presented. We need to educate patients, families, and whole communities. We need to reach out to churches and to support groups to help them understand and also to hear their concerns. We need to promote advanced care planning, especially for patients who have high risk. All dialysis patients, all patients with metastatic cancer, all patients with progressive dementia should have an opportunity to engage in advanced care planning. We need to coordinate across settings and try to avoid offering resuscitation when we feel it is harmful. Instead, find another way to discuss it rather than recommending it. So when conflict arises, my approach and what I recommend to my teams is to listen carefully for the patient's or family's deepest concerns. What are they hoping for? Let's bring in interdisciplinary emotional and spiritual support, because it's not all about technical jargon. In fact, that gets you in the door, but then you've got to discuss all those other things going on in the thought processes and at stake in these complex decisions. And we need to guide people. This isn't choosing chocolate or vanilla cereal. If your opinion is strongly felt, you can make it known. Another way to deal with conflict is to avoid it. Fine, focus on something else. If it's going to cause more harm to deal with this conflict, I will discharge a patient on hospice and encourage the hospice and the family to discuss code status at a later date. If you're going to do that, you just need to bring all parties to the table. Sometimes it's better to kick the can down the road. Another way is to compromise. So you can meet halfway, you can do time-limited trials. All right, he'll be full code for now. But if a week from now he's worse off than he was now, then I think it's going to make more sense at that time, because I know you're still hoping for recovery. Let's see what road he's on in a week. And sometimes you do have to say no, and for this you do need specific criteria. I'd like to work towards some sort of clinical pre-code risk stratification or assessment that we can use and document to empower clinicians to withhold CPR. Never would I say the clinician cannot do CPR if the family's sitting there asking for it. But I'd like to empower them to say no and avoid the harm to themselves, the body, and to the patient's journey. You need to document it, hold family meetings, bring in the primary care physician and chaplain or pastor, develop policies, engage in dialogue with the oncologist, with the trauma surgeons, and the other people who are also caring for these patients. We need to offer support for staff who are involved in codes. I feel like we need to have debriefing sessions for every code, because there's always a risk of harm in carrying some sort of story or image that can work against your own hopes as a professional. Perhaps we need review processes involving committees. At the end of the day, there might be cases where we do transfer people, but to me that seems like the last resort. Sometimes we just have to say no. What we can't do is continue this status quo of unmitigated choices versus futility assessments where we're tangled up in code blue discussions. It's harmful, it's ineffective, and it causes suffering to patients and providers. Nor can we engage in deception where we fail to accurately document discussions, and we cannot walk to the codes or not code a patient at all. We can't act alone. It's less effective in achieving the goals of medicine, and it leaves us open to professional liability. And that's the end of my talk.
Got time for just a question or two.
You may have a question?
I just want to ask a question. Is it a question of educating family members, but what exactly CPR is? It's not a panacea, that it's very brutal, it's very hard on the patient.
So the question is about, is it just a matter of educating families about what CPR is and what the harms are that come from it? And that's a great question. Would that were it so? All right, I think we would try that. And it's interesting how it can work both ways. If you come out too strongly against it, then you lose trust.
And outcomes are very poor.
People need to know this. People need to know the outcomes. People tend to be, I mean, especially once you're on the road of desperately seeking rescue from cancer. It's very difficult for this stranger that you're meeting in the hospital to say, well, when your heart stops, do you want us to help you? Right? First of all, it's a botched question, right? It needs to be, if your heart stops in the hospital, I promise we are going to help you. I promise we'll rush to your side. If you're choking on something, we're not going to let you die from that. We're going to try to take it out. If your sugar drops or you need oxygen or medicines for your heart, we're going to do anything and everything we can to help you. What I don't recommend, ma'am, sir, is if your heart is stopped and we can't get it going with ordinary measures, if you're dying and we can't save you with measures that don't hurt you, please don't let us hurt you. If we do chest compressions on you, we will break your ribs and there's almost no chance you'll survive to the hospital. We'll take an opportunity to let you pass peacefully if that's what it has to be and turn it into something else. And I'll tell people what my patients tell me. I'll say, sometimes my patients say, when the Lord calls, I'll be ready. Or I do want a peaceful passing. Or I don't want to die on machines. Or I don't want my family to have to make a tough decision and live with that responsibility. When I tell that to patients, sometimes they'll say, oh, yeah, try to save me, but don't do those heroics. But sometimes it doesn't work. It can backfire. And that's particularly because we live in an age when you're going to meet 100 doctors when you go to the hospital. And you don't always have a primary care physician who's able to stay involved with you, who you already trust going into the hospital. So someone who leads too strongly with, well, we don't want to do CPR on you, there's a risk of not trusting them. Why? You're going to withhold something from me? You're not going to even try? How can you give up before something like that's even happened? So obviously the context makes it very difficult. And part of that is the emotional stuff that I identified. It's also these doctor-patient relationships, which these days are very complicated, and the expectation of rescue through high technology is just built in.
Yeah, unfortunately, we as nurses, we don't have the time sometimes to sit with the patient at the side of the bed at night. Usually it's during the night hours when they are most afraid and they know that they're dying, but they need someone to be there just to listen to them and help them to progress to the understanding that death is near. Because when they meet a new nurse, they don't understand and she doesn't know them. So we as nurses need to build that rapport with that patient because they feel that we are the bridge that helps them to accept death and to accept CPR. And it may take a few days or a few, even maybe a week or so until they get to that point. But like in that movie with Wick, the movie Wick, when the nurse was there in the middle of the night and she was sharing popsicles with the patient, and then the patient told her she didn't want anything, she didn't want CPR, and that was it.
So the observation is what's lost when we don't have time to sit with patients in their darkest hours, right, at night, when things are more peaceful and maybe their confessions can come out. Maybe it's easier to talk about things. And I take that literally and as a metaphor. I think it's a keen observation. And the truth is that 21st century hospitals are not built for intimate conversations.
Just that.
And there's something good about that, right? Because they're not, the upside of that is that our technology is, in general, far more effective than it used to be.
So hospice, that's why it's good to have them on to transfer to hospice as soon as possible. To get that conversation going as soon as possible.
Right, so having conversations early will allow that hospital visit to maybe work in a different way. Maybe the conversations can be better held before you go to the hospital. It's up to you.
I'm sorry, we ran out of time for this one.
No, well, I can ask him after. I thought when you're on hospice, there is a DNR. There's a do not resuscitate with hospice.
So I'll answer this. So you don't have to be DNR to be in hospice.
You don't?
Most hospice agencies either will require it or will nudge towards it, but many will also accommodate, but they'll say this. If you have a cardiac arrest and our nurse is at your house, he or she is not going to call 911. She's not going to do CPR. She'll help make sure your loved one's not suffering or dying from something that's easily fixable. But we do believe it's going to cause more harm than benefit, and we're not going to participate in a full ACLS attempt at resuscitation. But I think it's a myth that you absolutely can't be in hospice while being full of code. I have a lot of patients who I refer to hospice who are still hoping for a miracle. We're still hoping for our high technology. But it's just a conversation you got to have with the hospice if they feel comfortable with taking the patient as they are. If we all know they're going to die, why withhold a service that could help them? But it's a very careful dance, and it's about the personality of the patient and family, and also the personality of that particular hospice agency. Thank you all so much.
Thank you.